All right, guys, let's get busy talking about major depressive disorder. And in major depressive disorder, test writers have a heyday with trying to find ways to make you make mistakes. So things to be on the lookout for this on test day is going to be traps regarding number of symptoms, traps regarding management, okay? These are where the test writers are going to try and get the best of you. So let's work through each of these things. So let's talk about the timeline. We need persistent symptoms lasting greater than 2 weeks. That's super high yield here. Additionally, history is going to be really important here. So we're looking for things like significant loss, life changes, disability, old age and loneliness, and just plain old idiopathic. Now, the next most important thing is the diagnostic criteria in terms of symptoms. So we need greater than or equal to 5 out of 9 of these symptoms, including depressed mood or anhedonia. So anhedonia simply means loss of pleasure for things that used to make you happy. Now, in children, we're going to also be able to qualify irritability as one of these symptoms. So I want to give you guys a really good, solid mnemonic for making sure you know all of these symptoms, and that's going to be called SIG-E-CAPS. So SIG-E-CAPS is a way to remember each of these. So the S stands for sleep disturbance. This could be an increase or a decrease in the amount of sleep. Next is going to be interest in pleasurable activities, and that's going to be the anhedonia, so the decrease in interest in things that used to make you happy. Next is going to be guilt, pretty self-explanatory. And then we also have energy. So this is usually going to manifest as decreased energy. People oftentimes are going to feel no motivation to do things that they used to. Next is going to be concentration. A decrease in concentration is a symptom of depression, as well as changes in appetite. And this can be an increase or a decrease in the amount of appetite you have. Next, we have psychomotor retardation or agitation. And this is going to be when patients are going to have like a mental slowing. So they're going to seem kind of dull. They have like trouble with like motor skills. This is what we describe as psychomotor retardation. Lastly, suicidal ideation. So if patients are considering, planning, talking to you about suicide, that also qualifies as one of the SIG-E-CAPS criteria. Now let's talk about management. So when it comes to management of major depressive disorder, we're going to first always want to screen for suicide risk. So if that is an option in question stems, you should be going for that because it's important to make sure our patient is not at risk for suicide. Next, we're going to screen for previous manic or hypomanic episodes. And this is important because some of the depression treatments can exacerbate mania or hypomania, which we're going to see in bipolar disorder. Now let's talk about first-line management, which is going to be cognitive behavioral therapy and SSRIs. This is the gold standard treatment that they like you to choose. However, I want to note that there are always going to be exceptions on test day, depending on our patient's previous medical history and side effects that they want to avoid. But in terms of your first choice, with nothing else to worry about, CBT plus SSRI is the way to go. Now, we have other second-line therapies like SNRIs, bupropion, mirtazapine, electroconvulsive therapy, and ketamine. These are all options for major depressive disorder. However, they all come with their own side effects. So I wanted to talk through a table with all of the important indications and contraindications for depression therapy. So starting with SSRIs, we talked about these being the first line treatment. These are your go-to. The contraindications for this would be a history of mania or hypomania. And this is because we don't want to exacerbate mood disturbances in patients who have a possibility of having bipolar disorder. Next, we'll talk about SNRIs, which are great if patient has fibromyalgia or neuropathy as well that they want treated. Contraindications here could be hypertension because our SNRIs are going to increase vascular tone due to their sympathetic activation. Next, we have bupropion. So this is going to be great for patients who want to stop smoking, patients who want to avoid the sexual side effects, such as like low libido, low sex drive that we can sometimes see with SSRIs. So that's a great option if the question specifically mentions that this patient wants to avoid sexual side effects. Also, it's going to help with weight loss. So that's another thing that this could be helpful for. Now, contraindications is a history of seizures or eating disorders. And why is this? This is because bupropion actually lowers the seizure threshold. And we know that patients who have eating disorders tend to have really low BMIs and malnutrition, and this puts them at a risk for seizures. So we want to avoid bupropion in this population. Next, let's talk about mirtazapine, which is going to be useful for our patients who are going to need to gain some weight or our patients who are having trouble sleeping. So malnourishment and insomnia, this is a great option for those patients. Now, the one caveat here is that it can cause hypercholesterolemia. So in patients where you're worried about their lipid panel, maybe choose a different agent. So when it comes to MDD, remember guys, it's important to know timeline, the specific number of symptoms that are required for this diagnosis, as well as the indications and contraindications for management. All right, guys, let's get busy talking about our depression subtypes. Now, our test writers like to ask specific questions about these subtypes of depression. I'm going to fill you guys in all you need to know about these different subtypes. So let's talk about MDD with psychotic features first. So this is going to be major depressive disorder plus patients presenting with psychotic features. Now, we defined psychosis in the first video of this chapter, but just to review, psychosis is going to be defined by at least one of the following, and that's going to be delusions, hallucinations, and disorganized thought. Put that on top of major depressive disorder, and you have MDD with psychotic features. So, like we said, MDD plus symptoms of psychosis. Additionally, the psychotic symptoms are usually going to be when the patient is feeling the most depressed. So when they're at their lowest point is where they're going to exhibit these symptoms of psychosis. So this is what the mood congruent and occurring during severe depression means here in these notes. Now, in terms of our management of this, we're going to use antidepressants and atypical antipsychotics plus or minus electroconvulsive therapy, also called ECT. ECT is really beneficial here because ECT both treats severe depression and it treats symptoms of psychosis. So this is a really great option for patients with this subtype. Now, let's talk about our next subtype, which is going to be MDD with seasonal pattern. This used to be called SAD, which was a mnemonic for seasonal affective disorder, meaning you get really depressed during a certain season. Now, this season is almost always going to be winter or seasons that have less sunlight because we know that our circadian rhythm affects our mood, affects our sleep patterns. And so when patients are experiencing less hours of daylight, they get MDD with seasonal pattern. Now, there are some criteria here that we have to pay attention to. So the criteria are same season in greater than or equal to 2 consecutive years, as well as most years in individual's life. So basically, if they're getting depressed every winter, there's a good chance they have MDD with seasonal pattern. Now, the treatment to this is pretty similar to MDD. We're going to be using traditional MDD management, so like SSRI and CBT would be first-line therapy. However, we can add on light therapy. So we basically give these patients like a little light that they can put on their desk, and it basically simulates the sun, and it gives them like more hours of light, and it relieves some of their symptoms associated with the seasonality of this subtype. All right, so next subtype, persistent depressive disorder, also called dysthymia. And this is a milder but more prolonged form of MDD. So remember, MDD, we just needed 2 weeks of 5 or more SIGI CAP symptoms. Whereas here in persistent depressive disorder, this is going to be greater than or equal to 2 depressive symptoms, but it has to occur for greater than 2 years. So that is going to be the giveaway here, is that these patients are going to be described as having a mild but really prolonged course of depression. I should also note here that we only need 1 year of symptoms for our children. Now, it's also important to note here that they need less than or equal to 2 months of remission. So if they go longer than 2 months without any depressive symptoms, they are disqualified from this diagnosis. So I want to use our little time chart here to talk about some of these subtypes that we just mentioned. So I'm going to make a little label over here called winter. And like, let's say this is the winter period, and we're going to have symptoms of depression all the way down during winter. This would be a pattern of someone with MDD with seasonal pattern. Now I want to draw someone who would have persistent depressive disorder, which is going to look more like this. So they're going to start here and they're going to come down and they're going to be kind of mildly depressed all along the way here until we get out to 24 months or greater than 2 years. And so that's going to kind of be the difference in the symptom profile and the timeline of these two subtypes. Lastly, let's talk about depression with atypical features. Okay, this is going to be what I call Thanksgiving depression, okay? And my mnemonic for remembering this is all about Thanksgiving dinner, okay? And this is because this type of depression is characterized by mood reactivity. What does that mean? It means that these patients get like little blips or little moments of happiness when they're doing something that they enjoy. And so for me, Thanksgiving dinner is a really happy time. I get to like eat a lot of food and just kind of chill out and relax. And so my depressive symptoms kind of would go away during Thanksgiving dinner if I had this type of depression. Additionally, this type of depression is accompanied by somatic symptoms, such as increased appetite, increased sleep, and leaden paralysis. Now, what is leaden paralysis? Leaden paralysis means that your legs and your arms feel really, really heavy. So just picture Thanksgiving dinner. You have a huge appetite, you eat a lot of food, then you get really sleepy, and your limbs get heavy because you don't want to move from the couch. So this goes into the rest of the Thanksgiving dinner mnemonic. Lastly, sensitive to rejection from friends, family, and acquaintances. Think about Thanksgiving dinner. A lot of times you're going to see family members that you haven't seen all year, and they're going to be the first person to criticize your new boyfriend, your new job, what you're doing with your life. And these people are really sensitive to criticism. So I like to use that part of Thanksgiving dinner as a reminder of this aspect of this subtype of depression. Lastly, we'll talk about management. It's going to be just the same as MDD. It's going to be CBT plus SSRIs. So I hope all of these make sense as specific subtypes of MDD that test takers can ask on test day as a way to get you to reach for more and more points. And now you guys know all the specific nuances of these subtypes.